You are listening to the Pregnancy Podcast with Vanessa Merton. Hello, thank you for tuning into the Pregnancy Podcast. In today's episode, we're talking about what to expect with a hospital birth. The vast majority of birth in the United States takes place in a hospital. This offers around-the-clock staffing, broad pain management options, and surgical capacity. Plus, a hospital has a NICU on site in the event your baby needs additional care. Hospitals also come with policies, routines, and a care model that shapes your experience in very specific ways. Whether you have already decided on a hospital birth, are weighing your venue options, or you want a backup plan, this episode will prepare you for what to expect. Learn what makes a hospital birth distinct, who provides care, and what happens from the time you arrive until you're discharged. Plus, all of the interventions available and the evidence on outcomes. You can find the full article and all of the resources for this episode at pregnancypodcast.com/hospital. You're on the public feed of the podcast, which means you'll get access to the last year of episodes and hear advertisements. Today's episode walks you through everything on a hospital birth. If you're looking for more evidence-based deep dives like this one, premium members get access to every single episode of the podcast, all ad-free in a private feed in your favorite podcast app. Check it out at pregnancypodcast.com/premium. Zoller goes above and beyond in formulating their prenatal plus DHA. They use high-quality ingredients like the active form of folate, bioavailable iron, and essential nutrients like omega-3s. In May of 2026, save 40% off the Zoller Prenatal Plus DHA on Amazon with the code PREPODS40. You can always check for the current promo code at pregnancypodcast.com/vitamin. The VTech V-Hush stroller rocker gently rocks your baby's stroller or crib so they can sleep peacefully anywhere. It has 3 motion levels, an amber nightlight, and built-in soothing sounds and lullabies. Check it out at pregnancypodcast.com/VTech. 8 Sheep Organics makes amazing 100% clean, natural pregnancy products. From skincare to treating common symptoms like stretch marks with clinically proven ingredients, 8 Sheep Organics has you covered. Every product comes with a 100-day happiness guarantee. If you're not 100% happy with your purchase, simply send them an email and they'll get you a refund, no questions asked. Check out 8 Sheep Organics and save 10% when you go to pregnancypodcast.com/8sheep. A hospital birth is exactly what it sounds like, but the specifics can vary a lot from one facility to the next. You may give birth in a community hospital with a single labor and delivery floor, an academic medical center that has maternal fetal medicine specialists and a level 4 NICU, or somewhere in between. Some hospitals have hospital-based midwifery practices, while others are exclusively staffed by obstetricians. Some hospitals offer water birth tubs, others do not. And then, of course, the policies, the provider training, and all the on-site resources can influence your experience. The United States is overwhelmingly a hospital birth country. About 98% of births occur here, with the remaining 2% split between home births and freestanding birth centers. This was not always the case. In 1900, almost all U.S. births occurred outside of hospitals. By 1940, that figure was down to 44%. By 1969, hospital births had reached 99%, and they've stayed roughly around that level since. Hospital birth is the default for a lot of reasons. It's the venue that most insurance plans cover most easily. It's the only setting that's equipped to handle every emergency, including those that could require surgical intervention. In the U.S. medical model, this is where most obstetricians are trained and where they practice. And if you have a high-risk pregnancy or you have any complications, a hospital is almost certainly the recommended venue. If you have a low-risk pregnancy, you have more options available. But even then, many low-risk mothers still choose a hospital setting. So this episode will focus on hospital birth, what that looks like, how to navigate it, and then birth centers and home births will be covered in a separate episode. There's a few defining features that really set a hospital apart from a birth center or a home birth. The first is emergency capacity. An OR is steps away from your labor and delivery room. You have anesthesia on site. You have a NICU if you need it for your baby. In an emergency, response time is measured in minutes. Hospitals also offer a wide range of pain management options, some of these that you will not find at other venues. If you know you want an epidural, then your only option is a hospital. That's the only venue where you can have access to that. Hospitals also have shift-based staffing. Nurses typically work in 8 to 12-hour shifts, and then doctors take call-in rotations. What this means is that the person that provides your prenatal care may not necessarily be the same doctor that attends your birth. Most of your labor, you will be supported by labor and delivery nurses rather than your doctor or midwife, and you may meet several nurses or providers across a longer labor as shifts change. This is a feature of how hospitals function. The benefit is that there is always someone available. The downside is that you have less continuity of care. One way to maintain continuity of care, meaning you're seeing the same person throughout the entire experience, is to work with a doula. A doula is a trained professional that provides continuous emotional, physical, and informational support throughout your labor. And unlike a doctor, a midwife, or nurses, they don't change shifts. They're with you for the duration. If continuity of that relationship matters to you in a hospital setting, a doula is one of the most reliable ways to build that in. Hospitals also come with a lot of policies and protocols. Some of them are clinical, like when to recommend a cesarean or how often to do vaginal exams. Others are administrative, like how long you'll stay, who can be in the room with you. And then there's others that are about liability and risk management. All of these shape the experience in ways that might not be obvious until you're in labor. And the more that you understand the policies at the specific hospital before you go in, the fewer surprises you'll run into. In a hospital birth, your care provider is most often an obstetrician. Obstetricians are physicians who complete medical school, followed by a 4-year residency in obstetrics, and they handle the full range of pregnancies, from low risk to high risk. Most U.S. births are attended by obstetricians. Some hospitals also have certified nurse midwives on staff. These are registered nurses with graduate-level midwifery training, and they typically care for low-risk pregnancies in a hospital setting alongside obstetricians. If you're working with a certified nurse midwife and something becomes higher risk or requires surgical intervention, then an obstetrician would step in. The difference between obstetricians and midwives isn't just credentials. It's really a difference in the care model. Midwifery-led care tends to emphasize longer appointments, more time spent on education and shared decision-making, lower rates of routine interventions. The obstetric model tends to be more efficient time-wise, and more interventions tend to be used. Neither is universally better, and individual providers within each model can vary enormously. Both midwives and obstetricians are very qualified to help you navigate labor. Your routine prenatal care will follow a standard timeline regardless of where you plan to give birth. If you are planning to have your baby at a hospital, your prenatal care typically takes place at your provider's clinic or their office, not at the hospital itself. So while the clinical content of that prenatal care is similar no matter what venue you choose, the time that you spend with your provider and the focus of your visits can differ. And those differences are really more about the contrast between obstetricians or OBGYN-led care and midwifery care than about hospital versus birth center or another setting. It just so happens that OBGYNs and obstetricians tend to be hospital-based. There's a few things that are worth taking care of well before you go into labor at a hospital. The first is to take a tour. This allows you to see what the labor and delivery floor looks like, to see how the rooms are set up, and to find out what amenities and tools are available. A tour will also cover practical logistics, like which entrance to use when you arrive, where you should park, and what to do if you arrive after regular hours. If your hospital allows you to pre-register and fill out any admitting paperwork ahead of time, provide your insurance information, do it. That's the last thing that you want to be doing while you're going through contractions. Many hospitals will also ask for a birth plan so that they can put it in your chart in advance. If they don't ask for it, you can always send them an advance copy and ask that they include it in your file. If there are specific aspects of your birth experience that are really important to you, you need to find out what the hospital's policies are. And the best time to find out about how a policy will affect your birth plan is during a prenatal appointment, not when you're in active labor. This applies to things like mobility during labor, eating and drinking, electronic fetal monitoring, water immersion, who can be in the room with you. There's a lot of logistics that are impacted by policies and procedures. If you have a scheduled induction, lucky you, you know exactly when you need to be at the hospital. Otherwise, your doctor or midwife should give you specific guidance on when to actually go to the hospital in labor. This is usually based on contraction patterns. A common rule is 5-1-1. That means that your contractions are 5 minutes apart, lasting for 1 minute each for at least 1 hour. If you are not sure whether you're in labor, call your doctor before getting in the car. Your care provider can usually tell a lot about how your labor is progressing by talking to you on the phone. When you arrive at the hospital, you're going to check in to the labor and delivery unit. If you arrive after hours, you may need to go through the emergency department. Once you're in, the staff will evaluate you to determine whether you're in active labor and should be admitted, or whether it's a false alarm and you should return home and come back later. Your first stop is typically a triage room. A nurse will check your vital signs, so your pulse, blood pressure, temperature. You're going to get a series of questions like what your due date is, when contractions started, how far apart they are, whether your water has broken, whether you've noticed any bleeding or changes in your baby's movement. If your water has broken, your provider will ask about COAT. COAT is an acronym that stands for color, amount, odor, and time. Clear or slightly straw-colored fluid is normal. That's ideally what you want to see. Green or brown fluid would suggest meconium, and that could change what happens next. The time your water broke is also relevant because the risk of infection increases the longer that your baby is exposed without those protective membranes. Your provider may track that on a 24-hour clock, after which the risk of infection increases and some interventions may be suggested. Hospital policies vary on how strictly that timeline is enforced. Either way, it's important to take note if your water breaks as to when that happens. Standard practice at most U.S. hospitals is to hook you up to an electronic fetal monitor for about 20 to 30 minutes when you first arrive. This involves 2 belts that go around your abdomen. One is tracking your baby's heart rate, and the other is tracking your contractions. This will give a baseline of how your baby is tolerating early labor. It is worth knowing there's a Cochrane review that looked at admission cardiotography in low-risk women, and they found that an admission CTG, that's the machine that they're using, increases the likelihood of a cesarean by about 20% without clear evidence of benefit to the baby. The reviewers actually recommend against routine admission CTG for low-risk women. Despite this, in practice, most U.S. hospitals largely continue this routine. If you want more detail on monitoring options, including continuous versus intermittent, using telemetry, what the research shows on all of those options, of course, there is a full episode on it. After fetal monitoring, your provider may suggest a vaginal exam. They will do that to check your cervix for dilation and effacement. This helps confirm whether you are in active labor, and it can give a sense of how far along you are. There are pros and cons to routine cervical checks, and there are questions about what the data from this actually tells you. We won't get into it in this episode, but of course, you know it's covered on another episode of the podcast. Your provider will also feel your abdomen. They want to determine your baby's position. They want to make sure that your baby is head down. If they can't confirm the position by feeling your belly, then they may do a quick ultrasound. Most U.S. hospitals will recommend a cesarean if your baby is breech, meaning that they're not head down. If your baby was head down in the final weeks of your pregnancy, it's pretty rare for them to flip at the last minute. They don't have a whole lot of room to move around at the end of your pregnancy, so I wouldn't worry about that, but that is why they're checking for your baby's position. After all of these exams, they'll decide whether to admit you or send you home. If you're not yet in active labor, it may feel like a big disappointment to have to go back home, but that's really where you want to be in early labor. At home, you can move around, you can eat, you can rest, you can just stay relaxed, and that tends to be more comfortable and may help labor progress. So being sent home isn't a failure. You wouldn't be the only first-time mom to have a false alarm. You're better off going in and being sent home than ignoring signs and going into labor before you get to the hospital. Once you are admitted, then you move to the room where you will labor and give birth. You will be assigned a labor and delivery nurse as your main point of contact for the duration of their shift. This is your person. Do not be shy about asking for what you need, whether that's ice or a wet washcloth, a birthing ball, dim light, a few minutes of quiet. If you have a written birth plan, which if you listen to this podcast, you know I'm a big advocate of, make sure that it is in your chart and that the nurse has a copy. And if anything in particular is very important to you, say it out loud. Nurses change shifts, and even great handoffs can miss important details. So a really short, clear statement like, I'm planning an unmedicated birth. Or maybe you could say, hey, I just need you to know that I want an epidural as soon as possible, can help your team support what you want. The environment that you labor in significantly affects how labor unfolds. And that's because oxytocin, which is the hormone that drives contractions, is most easily released when you feel calm and safe. Stress hormones like adrenaline and noradrenaline can actually slow labor down. A Cochrane review of nearly 12,000 women compared bedroom-like alternative birth settings within hospitals to conventional labor wards. And what they found was that the women in the alternative settings were more likely to have a spontaneous vaginal birth, less likely to use pain medication, and reported greater satisfaction with care. You can't redesign a hospital room on the spot, but there are tweaks that you can do that can make a big difference in your environment. You can dim lights. You can lower the volume on monitors. You can bring familiar items into the room with you, or ask staff to speak softly. Small adjustments can really stack up. Next, many hospitals start an IV routinely when you get admitted. An IV is required if you need antibiotics. For example, if you tested positive for group B strep, if you're getting Pitocin to augment your labor, if you have an epidural, or of course, if you become dehydrated. For low-risk women that do not need any of these things, a saline lock is often an alternative. So a saline lock is an IV catheter that's placed in the top of your hand or in your arm, and it's not connected to a fluid line. If you end up needing fluids or medication later, it's already in place and it's quick to administer that. But if you don't need those, then you're not tethered to a pole. You may have also heard the term hep lock instead of saline lock. They used to use heparin flushes. Most hospitals now use saline flushes instead, but the name has stuck in some places. If you have specific preferences regarding IV fluids or a saline lock, ask your provider ahead of time whether running an IV is required upon admission or if a saline lock is an option. Hospital policies on things like movement, food, and drink can vary widely and can shape really how your labor unfolds more than you might expect. Some hospitals encourage walking and position changes. Some venues have tools available like birthing balls. They may offer the option to labor in the shower or a tub. Movement is important because research shows that walking and upright positions reduce the duration of labor, the risk of cesarean birth, and the need for an epidural, with no increase in interventions or negative effects on mothers and babies. There's other research on second stage positions. The second stage of labor is the pushing stage, that found that women who used upright positions more than half of the time had more effective contractions, more perineal muscle relaxation, significantly shorter births, fewer assisted deliveries, and fewer cesareans. Even if you are limited to a hospital bed, you can sit in an upright position. There's a lot of things that you can do to take advantage of the most effective labor positions, even if you have limited mobility. Next, we have to talk about eating and drinking. U.S. hospitals tend to follow ACOG's position. ACOG is the American College of Obstetricians and Gynecologists. They support clear liquids in active labor, but they restrict solid food. The historical concern that created this was about aspiration in the event of an emergency cesarean under general anesthesia. That's very rare. It's very rare that a cesarean is done with general anesthesia. Usually you're not all the way out for that. A study of nearly 50,000 cesarean deliveries found that the aspiration incidence was 0.013% under general anesthesia. The American College of Nurse Midwives takes a different position. They support light eating during labor for low-risk women, as does the American Society for Anesthesiologists. A Cochrane review found that there are no benefits or harms from restricting food and fluids during labor in low-risk women, and concluded that women should be free to eat and drink in labor as they wish. This is a great example where you have a gap between the evidence and standard hospital practice, and policies will vary by hospital and by provider. If things like mobility, water immersion, eating during labor are important to you, ask your hospital or ask your care provider ahead of time what their policies are so that you know what to expect. We talked about electronic fetal monitoring upon admission. Hospitals also use this throughout labor to track how your baby is tolerating contractions. There's two general categories here. You have traditional electronic fetal monitors, which strap belts around your abdomen and you're connected by wires to a machine. You also have telemetry monitoring, which is essentially a wireless device. Not every hospital has telemetry monitors, so if that's something that's important, I would ask about that ahead of time. Depending on your circumstances, you may also have options for whether monitoring is continuous or intermittent. If your labor's progressing well and you and your baby are doing fine, You may not need to be hooked up to a monitor for the entire duration of your labor. If you have an epidural, continuous monitoring is typically required, also if you are receiving Pitocin or if you are high risk. But if you are low risk and you are not using those interventions, then intermittent monitoring, this can also happen with a nurse just checking the heart rate periodically with a Doppler, is also an appropriate choice. There's a Cochrane review of 13 trials and more than 37,000 women that compared continuous electronic fetal monitoring with intermittent auscultation. Continuous monitoring did not reduce perinatal mortality and it did not change cerebral palsy rates, but it did significantly increase the rate of cesarean and instrumental births. Next, let's talk about your pain management options. Hospitals have the widest range of pain management options, and these basically fall into two broad categories. You have your non-medical options. These would be available in any setting. This is things like changing positions, hydrotherapy in a shower, breathing and relaxation techniques, counterpressure massage. If you are interested in a water birth, first you need to find out if that's an option at the hospital. Also, there's a joint committee opinion between ACOG and the American Academy of Pediatrics that supports water immersion during the first stage of labor as a reasonable comfort measure, but they recommend that the birth itself take place on land. So in practice, most U.S. hospitals will allow you to labor in a tub if that is available, but they will require you to get out for the second stage of labor when you're pushing. There are many medical options, like an epidural, that is only available in a hospital setting. An epidural is by far the most commonly used pain relief. Data shows that over 75% of vaginal births use an epidural or spinal anesthesia, and that varies a lot by state. It's 50% in Alaska and 85% in Louisiana. An epidural typically takes about 30 to 45 minutes from the time you ask for it until it is fully working. Once it's in place, you will have continuous electronic fetal monitoring, you'll have IV fluids, and a urinary catheter, and that's because you will not be able to fill your bladder. Your mobility, of course, may also be limited, and depending on the dosing, you may have some leg movement, but you may have difficulty walking on your own. That's why many people with an epidural tend to be limited to a hospital bed. Like any intervention, there's pros and cons, and epidurals are highly effective for pain relief. It's also worth noting you can absolutely have an unmedicated birth in a hospital setting, and plenty of moms plan for and are successful in going through birth without pain relief in a hospital. For a lot of moms, it gives them peace of mind just to know that that option is available if they decide that they want it or if it becomes necessary. Next, we're going to talk about some more hospital policies and what happens after you actually have your baby in a hospital. Before we do that, I would like to thank the sponsors that have supported this episode. A lot of companies offer exclusive discounts for pregnancy podcast listeners, and you can always find discounts and promo codes at pregnancypodcast.com/resources. It's challenging to meet your increased nutrient needs during pregnancy through your diet alone. Taking a high-quality prenatal vitamin is the easiest way to ensure that you and your baby are getting all of the vitamins and nutrients that you need. My top recommendation for that is the Zoller Prenatal Plus DHA. My top priority with any vitamin or supplement is always high-quality, bioavailable ingredients. And Zoller formulates their vitamin on the latest scientific evidence. They're not relying on outdated RDAs that can lag years behind the research. Each serving includes 300 milligrams of DHA. This is a critical nutrient for your baby's brain and eye development. It also supports your mood, cognitive function, and it's important for your mood postpartum. Most prenatal vitamins do not contain DHA. This is just one detail on a long list as to why this is my favorite prenatal vitamin. In May of 2026, save 40% on the Zoller Prenatal Plus DHA on Amazon with the code PREPODS40. And you can always see the current promo code at pregnancypodcast.com/vitamin. If you've ever tried to get a baby to fall asleep in a stroller or a crib while you're trying to get things done, you know that the exact moment that motion stops, they're going to wake back up. That's why I love the VTech V-Hush stroller rocker. This is designed to solve this exact problem. It's a portable device, so it attaches to almost any stroller or crib with a universal mounting system, and it uses a gentle mechanical rocking motion to keep your baby asleep without you having to stand there rocking them. You can choose from 3 motion levels to match whatever works best for your baby. VTech packs in thoughtful details into their products, like a built-in amber nightlight, a rechargeable battery, soothing sounds, white noise, and lullabies to help your baby drift off and stay asleep. Soothe your baby to sleep anywhere with the VTech V-Hush stroller rocker. Check it out at pregnancypodcast.com/VTech. Let's get back to today's episode. For most of your labor, the people that are in the room with you include your partner or a support person, a labor and delivery nurse, and a doula if you have one. ACOG's committee opinion on approaches to limit intervention during labor and birth does state the importance of continuous one-to-one emotional support from trained personnel like a doula. ACOG acknowledges that this is associated with improved outcomes, including lower cesarean rates and higher satisfaction. Your doctor or midwife typically arrives much later in the process, often around the time that you are ready to push, and that can vary depending on the hospital and provider. Hospital policies on visitors and the support people that can be present can vary. Most hospitals will allow 1 to 2 support people plus a doula. You need to confirm the policy at your hospital well before you go in. You should also know whether other family members can be present, if children can visit, whether photos or videos are allowed during birth. You want to make sure that everything you're planning fits with hospital policies. The last thing you want to do is hire a birth photographer that can't actually be present. When you are close to birth, you're going to have more people come into the room. Typically, there will be your nurse, your doctor or midwife, sometimes a second nurse, and often a pediatric provider. This could be a pediatrician, a family physician, or a neonatal nurse practitioner. They're going to be there to check on your baby. Pediatric team is standard at most hospitals. They're not there because anything is expected to go wrong, but they're there because if anything does, you want them already in the room. Among interventions that are only available in a hospital setting is assisted vaginal delivery. Hospitals have access to forceps and vacuum extractors if they become necessary. An assisted delivery could be recommended if pushing is prolonged, if the baby's in distress and they need to be born more quickly, if you're too exhausted to keep pushing effectively. A vacuum is more common than forceps. In the US, forceps are used in less than 1% of births. Combined, operative vaginal deliveries account for about 4% of all US births. Like any intervention that could come up during labor, if your provider recommends an assisted delivery, they should walk you through why and what to expect. After your baby's born, there's a lot of things that happen in quick succession. Unless there's an issue or a reason to do otherwise, your baby is typically placed directly on your chest for skin-to-skin contact. This has well-documented benefits, improved temperature, glucose, respiratory stability for your baby, and reduced stress in both you and your baby. The umbilical cord can be left intact for delayed cord clamping if that is something that's important to you. Then your provider will deliver the placenta in the third stage of labor. And if you had a tear or an episiotomy, then repair also happens following that. Hospital policies can affect a lot of your options with these things, like delayed cord clamping, how the third stage of labor is managed. If you have specific preferences, be sure to discuss them with your provider well in advance. One mandatory hospital step that happens pretty early on is that you get identification bands. So you, your partner, your baby will get matching bracelets that have your information so that there is no question about which baby belongs to which parents. Many hospitals also attach a small security tag to your baby that will alert staff if the baby leaves a designated area. Now let's talk about procedures with your newborn. The first hour after birth is often called the golden hour. This is a window when uninterrupted skin-to-skin contact is really beneficial. You're trying to establish breastfeeding, your baby's transitioning to life outside the womb. There's a handful of routine procedures that are performed on almost all healthy newborns that happen shortly after birth. One is your care provider will assign an APGAR score at 1 minute and 5 minutes. APGAR stands for appearance, pulse, grimace, activity, and respiration. You don't need to memorize that. They're just looking for signs that your baby's doing well. They also weigh and measure your baby. Standard procedures in the US also include erythromycin eye ointment and a vitamin K injection. A lot of these initial procedures can be done with your baby on your chest so that you don't have to be separated from your baby, or they can be delayed so they don't have to interrupt that first hour. If protecting the golden hour matters to you, speak up. And of course, every procedure has pros and cons. You always have the right to ask questions so that you can make an informed decision. And you always have the option to delay procedures that are not urgent. There's a few other newborn checks that happen later, typically between 24 and 48 hours after birth, but before you go home. This includes a newborn metabolic screen. This is a heel prick blood test that checks for rare genetic and metabolic conditions, a hearing screen to test your baby's hearing, and a pulse oximetry screen for critical congenital heart defects. Before you are discharged, a pediatric provider will also do a full physical exam of your baby. At some hospitals, this is done by a hospital-based pediatrician or a neonatologist. At others, it may be done by your own pediatrician if they have hospital privileges and will come in for a visit. Most parents stay in the hospital for about 24 to 48 hours after a vaginal birth and about 2 to 4 days after a cesarean. The exact length depends on a lot: the hospital policy, how you and your baby are doing, your insurance. In the hours after you have your baby, you will be moved from a delivery room into a postpartum recovery room. Your partner can typically stay with you overnight. These rooms usually have a chair or a small couch that converts to a bed. A hospital stay is really a chance to take full advantage of being surrounded by experts. There's going to be a lot of new information coming at you and a lot of questions about everything: feeding, sleeping, diapering, what's normal, what's not. Ask all the questions. Most hospitals also have a lactation consultant on staff. Even if breastfeeding seems like it's going off to a great start, ask for a visit from a lactation consultant. A very brief visit can make sure that everything's going well. They can answer any questions and could potentially prevent any breastfeeding issues before they start. While you should be asking all the questions, if you prefer quiet, you're also welcome to ask for that. The flow of staff in and out of your room can be relentless, and it's completely reasonable to ask your nurse to coordinate a few hours of uninterrupted rest. You and your baby are going to be exhausted after birth, and you probably could use some sleep. Discharge in a hospital is its own process. Before you leave, you and your baby will both be examined. The hospital staff will go through a stack of information on how to care for an incision or a tear in your perineum, signs that you should watch out for, how to care for your baby's umbilical cord, signs of jaundice, feeding cues, and when to call your pediatrician. It's going to be a lot of information. A couple tips here. One, have your partner present for this conversation or another support person. They can help you remember it all later. I also recommend that you record the conversation. That way you can reference it later if needed. After that conversation, you will sign discharge paperwork. They may have you schedule your baby's first pediatrician appointment before you leave. Some hospitals may schedule postpartum follow-up visits. Bottom line here, the discharge process can take several hours. So if you are getting ready to go home, start that process as early as possible. Most infant car seats have a detachable carrier that pops out of the base. So the base remains strapped in your car and you just pop the carrier out. You're going to be positioning your newborn in the carrier before you leave the hospital room. So if you're nervous about whether your baby is positioned correctly, a nurse or someone from the hospital should be able to help. Let's talk a little bit about evidence on hospital birth outcomes. I want to be very clear here. If an emergency arises, a hospital is the best place to be. And thankfully, the majority of births don't result in emergencies. From the most recent data, the overall cesarean rate in the United States is 32.4%. The low-risk cesarean rate, so this is for first-time mothers with a single full-term head-down baby, was 26.6%. Cesarean rates vary widely by hospital and by provider. Some hospitals have low-risk cesarean rates under 20%, others are above 40%. Asking your hospital and your specific provider for their cesarean rate is not only a fair question, but it can be a useful data point, especially if you are aiming for a vaginal birth. Another thing is inductions. These have climbed steadily in hospitals for decades. Recent data shows that the total U.S. induction rate is almost 32%. So basically 1 in 3 women is getting labor-induced. This has been increasing for a few reasons. One is due to more medically indicated inductions. The other is a shift towards elective inductions at 39 weeks. This is something that came about as a result of the ARRIVE trial. Inductions do tend to lead to longer hospital stays, more monitoring, and more interventions overall. Depending on the circumstances, these can also be the clear right choice for you. Like anything, pros and cons, you need to determine what is the best decision for you. And there's not one right answer. Routine episiotomy is no longer recommended. Thankfully, rates have come down significantly over the past few decades, but these still vary widely by hospital and provider. If an episiotomy is something that you would like to avoid, you may want to ask what their episiotomy rate is and let them know that you would like to avoid it. I know we've covered a lot so far on hospitals. We're getting closer to the end here. Like any birth venue, there's pros and cons. The gap in a lot of ways between what the evidence supports and what is routine practice is a real gap. And understanding that can help you have more productive conversation with your provider about what is actually necessary for your specific pregnancy so that you're getting real individualized care. You're not being treated the same way that everyone is who is coming in labor. ACOG does acknowledge that many common obstetric practices are of limited or uncertain benefit for low-risk women in spontaneous labor, including things like routine continuous electronic fetal monitoring, routine IV fluids, or routine amniotomy. That's where they rupture the amniotic sac to break your water. This is really an evolving picture. And as more evidence comes out, as more mothers are asking about their options and advocating for themselves, hopefully we'll continue to see more shifts toward patient-centered care within the mainstream medical model and within hospital settings. This isn't something that would change overnight, but I think it is slowly shifting. We should also touch on insurance. Most health insurance plans cover hospital births as a standard maternity benefit. The cost of birth can vary a lot. A vaginal birth in the US is about $7,000 with insurance, about $12,500 without. A cesarean, much higher, that's $10,300 with insurance and around $17,000 without. Costs vary a lot by state. So these are just ballpark figures. What you actually will have to pay depends on a lot. The specifics of your plan, the cost of the hospital. Navigating all of that can be very confusing, but it's worth it to do your homework to confirm that your hospital, the provider are in network and really understand what's covered and what would be required for you to pay out of pocket so that you're not blindsided by bills later. Whether it's your plan A to have a baby in a hospital, or it's your backup plan if you need to transfer from home or a birth center, I highly recommend that you build a birth plan. And the Pregnancy Podcast has a lot of resources to help with that. I will link to all of those at the end of the article for this episode. I also highly recommend a backup plan. If you already know that you are having your baby at a hospital, and that you're planning a vaginal birth, a valuable backup plan may be a plan for a cesarean section. The reason that I highly recommend creating a backup plan is that, one, you're going into your birth with so much more confidence because you can navigate any scenario. But also, if things change during your labor and interventions are being employed or a cesarean is being recommended and you were not prepared for that, you don't know what your options are, which really means that you don't have a lot of options, and you're going to be very lost. If you have explored what a cesarean would potentially look like, if you know what your options are, you can advocate for what you want, and you're going to be much better prepared. There are episodes on cesarean birth and also an episode that really gets into more options for a gentle cesarean or a family-centered cesarean. Again, if you don't know your options, then you don't have any. I will link to both of those episodes in the article for this one. No matter where you plan to give birth, the single most important relationship is with your doctor or midwife. They're your trusted partner during pregnancy. They're going to help you navigate all of your decisions during labor. The more aligned that the two of you are before you go into labor, the closer you'll get to your desired birth experience. The best thing that you can do to prepare to navigate birth in a hospital is really to take advantage of working out all the details and your questions in your prenatal appointments. Ask about hospital policies, find out what your own provider's policies or general practices are, and how flexible they are with the things that are important to you. If you and your care provider are not on the same page, it's much better to find that out at 28 weeks than when you're in labor. You always have the option to change your doctor or midwife if it's not the right fit, but the earlier you do that, the better. Lastly, communication during labor matters as much as communication before. If something's being recommended and you don't understand why, ask. If you want time to think about something before agreeing to an intervention, ask for a few minutes. Unless something is a true emergency, which most of the time is not the case, there is almost always time for a conversation. For the vast majority of expecting parents, a hospital is the no-brainer default of where they want to have their baby. And for good reason. It's where 98% of all babies are born in the United States. It's the venue most covered by insurance, and it's the only setting that's equipped to handle every kind of complication. If you already know you're planning on a hospital and you feel great about that decision, fantastic. That is one less decision that you have to think about. That being said, hospitals are not your only option. Birth centers and home births are increasing in popularity, and both have their own pros and cons. I am a massive advocate of you knowing what your options are, because you really cannot make a confident decision about where to have your baby without understanding what's actually available. The more you know, the more confident that you will be in whatever you choose, whether that's a hospital or another option. Of course, this episode was your deep dive on hospital birth, and there will be separate episodes covering birth centers and home birth. To recap today's episode, I know this was a long one. There's a lot that goes into hospital birth. We talked about what it is, what makes it distinct, different from birth center or home birth, including the ability to handle emergencies, broad pain management options, the way that staffing works at hospitals. We also talked about the care provider model and how that can vary between obstetricians and midwives. We went step by step through what to expect from the time that you arrive until you go home with your new baby, and talked a lot about interventions that could be employed in a hospital setting. I would like to thank you for tuning into the Pregnancy Podcast today. I hope that you find this episode helpful. Please share this podcast if you have a friend that's expecting. So many listeners discover the podcast through recommendations, and I appreciate you sharing it. As always, you can reach me, Vanessa, at pregnancypodcast.com. You can read the full article and see all of the resources that accompany this episode at pregnancypodcast.com/hospital. If you're planning a hospital birth, there are premium episodes that go deeper into every intervention, pain management option, and procedure that was mentioned in today's episode. Pregnancy Podcast Premium members get access to hundreds of episodes, all ad-free, with evidence-based information that you won't find anywhere else. Check it out at pregnancypodcast.com/premium.